So this is going to be very brief because actually we touched on some of these issues yesterday. And as Mel has just explained, these themes, the first one was yesterday on healthcare delivery, and I'm speaking on human resources, and then Leslie will speak on leadership and governance, as well as financing. So we picked these four themes after, really, they date back to before our National Health Assembly in 2016. And since that time, we have done more work, and it's clear that these four themes are probably the most important ones of our health system. So if these were to be addressed with or without an NHI, they would greatly improve service delivery. So why is HR important? So human resources for health account for about 70% of spending in the health sector. So that's everything from medical specialists to cleaners. That's what comprises the human resources for health component. So it's the biggest item of recurrent expenditure. And actually, when governments reduce their budgets because of austerity, when they say there's not enough money, and we can talk about that later, when they say there's not enough money, the last thing to be cut, actually, is human resources for health, because they're political problems. You have contracts with people, so you can't just terminate their contracts. So the way, of course, this is being dealt with is the second bullet here. The way it's being dealt with, this austerity, this lack of money at provincial level, is that when posts become vacant because someone resigns or dies or somehow leaves the service, what's happening increasingly is that those posts either get frozen, which means the post still exists, but it's not being filled, or, which often happens, there will be deliberate delay in filling the post so that the province gets like 6 months of service from the other people before they fill the post which has been vacated. Are people with me? So these are the ways in which they save money, and all of this impacts negatively on how services can be delivered. So, all of this problem is built on a long-standing problem of inadequate supply and inequitable distribution of skills. What does that mean? As we saw yesterday, in Leslie's talk in particular, about the same amount of expenditure is going to public as to private. And as I've said, much of the expenditure is on health personnel, human resources for health. So if we look at the distribution between public and private, we find that about 50% of general doctors are in the private sector. More than 70% of medical specialists are in the private sector. Something like 90% or more of dentists, occupational therapists, physiotherapists, speech and hearing therapists are in the private sector. So near a very high percentage of the specialists are in the private sector. When you come to general doctors, it's the same in terms of the percentage, but the 50% in the private sector, as we heard yesterday, only caring for less than 20%, something like 16% of the population. And then when we get to nurses, actually this is the only group where the higher proportion is in the public sector. It's not in the correct proportion. It's not like 80% of nurses. It's much less than that. I can't give the exact figure, but it's somewhere around between 60 and 70% for 84% of the population. And so we have this huge problem of not enough human resources for health and very unequal distribution between private and public. And then when we look at the public itself, we find, and this is really part of our history, that a disproportionate percentage of staff are based at the higher level facilities. So we find that in particular, the primary care level, that's clinics and health centers, are poorly staffed. And even when you get to the big hospitals, they're understaffed, but they're not as understaffed as the lower levels of the health sector. And finally, there's the urban-rural inequality. So again, especially when it comes to doctors and specialists, the great majority are in the urban areas and in particular in the metros. So this means, and of course, as someone said yesterday, the private sector hardly exists in rural South Africa. It's true there are some private practitioners in some of the small towns. But if you get out to the rural provinces, there'll be whole areas, as we heard from our colleague from Northwest, there are whole areas where there's just no doctor at all, or just one or two doctors. I'm not saying doctors are everything, but there's really a big crisis in terms of the distribution. When you add together private, big hospitals, and rural, you find that actually rural primary care and rural community level are very, very poorly staffed. So one of the things we focused on as PHM over the last several years is community care workers or community health workers. So it's clear that there are not enough of them. Their scope of practice is often very limited. What do we mean by that? Well, the great majority of them, as you probably know, developed during the period between the early 2000s and now, really to deliver HIV and TB care. And many of them were employed, in fact, the vast majority were employed through NGOs, and they often were trained to do a very narrow set of activities to do with HIV in particular, but also TB. So you had people, and you have people, who are adherence counselors, for example, who make sure, or try and make sure that people stick to their treatment. They're people for both HIV and TB who counsel about treatment, who follow up people in their homes, sometimes take their treatment to them, and so on. So there are many areas of care at the community level and by community level I mean below the clinics, which aren't being catered for. So maternal and child health problems, other non-communicable disease problems like high blood pressure, diabetes, and so on and so forth, which aren't being adequately catered for. And we know that for NCDs, similarly to TB and HIV, people have to keep up their treatment. So it's quite difficult often for people who are living some distance from a healthcare facility to have the money and the time and so on to actually invest to go and fetch their treatment. So it's envisaged that community care workers should be able to do all of these things. Problem is, if they are going to do all of those things, then there need to be more of them. Because you can't expect a community care worker who is supposed not even to be working full time to actually do all of those 4 burdens of disease which we talked about yesterday. HIV and TB, maternal and child health problems, non-communicable diseases, and then problems of minor injuries and trauma and so on, and to be able to counsel people, and to be able to give health education, and to be able to link up with other sectors like water and sanitation and so on, because they are supposed to do all of those things. So Leslie showed the diagram yesterday of re-engineering primary healthcare. You remember that one? So in that one, amongst the many other things, these ward-based outreach teams, which are staffed mainly by community health workers, are supposed to do all of those things that I've talked about. They're even supposed to work with local government around environmental health like water, sanitation, and so on. So in order to do all of those things, we say as PHM that there need to be much larger numbers. And we have been campaigning for this for some time. So recently, government allocated, and our colleague from Section 27 yesterday, who spoke last, told us 1 billion rand has been allocated for community health workers. So we're very pleased about that. That is a partial victory. It's not nearly enough, because that amount will only employ about 30,000 community health workers. And we estimate that there need to be at least 60,000. And if we are to cover adequately like countries like Brazil do, we need more than that. We need at least 100,000 community health workers. And we calculate this by looking at the ratio of community health workers to population, right? So it should be more than 1 per 1,000 people. But actually at the moment, it's going to be something like 1 to 4 or 5,000 people. So this is a problem, especially in rural areas like Northern Cape or parts of Northwest or Eastern Cape, where people are very scattered. That would mean that a community health worker has to travel very long distances in order to cover the population that she is allocated. So another good thing that's happened, although it's not good enough, is that government is now saying, or they have said, that all community health workers will be paid the minimum wage, which is, as you know, 3,500 a month, which is the minimum wage. It's better than nothing, but terribly difficult to survive properly on 3,500 rand a month. I'm sure everyone will agree. So community health workers, care workers have complained for many years, and we've supported them in this, about their very poor conditions of service. Until very recently, and in fact it still persists in some provinces, they get a stipend, it's not a salary, of something between 1,000 and 1,500 rand a month. That's not enough. So the ones that are being brought onto the government payroll now are going to get 3,500. They complain about poor supervision and support, and that often they work in dangerous and unsupported conditions. So we've had a big campaign, and Mel, who may talk about this later, has been very involved in driving a process of trying to capacitate community health workers through our SAPUs, and some of us have participated, Louis and Tinashe and others, in helping community health workers to understand what their roles could be, including in addressing social determinants of health, like water, sanitation, and so on. So I've covered some of this. So we want this. We want this, and it's partially been achieved. We want many more than we've got. We want this, with decent conditions of service, good supervision, and psychosocial support, because it's very stressful work, and many community health workers talk about being abused, even sexually. They'll arrive at someone's home, and they won't find any woman there, and the man will take advantage, and so on. So we want this whole program, we think it's exceedingly important, to be beefed up. So we welcome the steps that have been made, but we will continue to push for more community health workers who can do more, who are allowed to do more. So just finally on this, community health workers in about 30 African countries are allowed to carry with them antibiotics to treat childhood pneumonia. Not in South Africa. So we know from the data we've got that there are children dying at home, especially infants under 1, of pneumonia. And we say, why can't South African community health workers give a Moxil antibiotic to those babies that they see who are breathing very fast? You don't need a stethoscope. You can count breathing, and I've seen CHWs in Rwanda, for example. They've got these kind of wind-up timers. So you can time how fast a baby is breathing, and if it's breathing over a certain number of breaths per minute, then and has a fever, you introduce antibiotics and you refer the baby up the chain. We're saying that should happen in South Africa, and so far that's been opposed, not so much by the health service, although they are part of it, but by the Pharmacy Council. They're saying it's dangerous to give community health workers antibiotics. And I always say to them, well, what's more dangerous than death? So we have these demands. I think I've covered most of this. That the CCWs, and the CCWs, community care workers employed mainly by NGOs, there were between 60 and 70,000 of them. So now there's going to be an issue because government is saying they can only afford, I think it's 32,000. So we wonder what's going to happen to the other 30,000. So the other 30,000 are quite likely, over the next short period, to start essentially undertaking labor action to say, well, why can't we also be absorbed into the system? So in terms of critical posts, other critical posts, that is posts at primary level clinics and health centers, secondary level district hospitals, and even tertiary level, the bigger hospitals, we want those posts to be filled, not just clinical posts. There are other posts, for example, social work posts, which are desperately needed. And we also want posts at lower levels of the sector to be greatly expanded. So you will have heard the term mid-level workers. So mid-level workers are people like clinical associates. They're people that have got a few years training and can do the work that doctors do on basic conditions, and if they can't handle some things, they refer them up the chain. These work very well in other African countries, but in South Africa, our clinical associate program has stalled. And then many of us have been arguing for some time for community-based rehab workers. So that's because physiotherapists, occupational therapists, speech and hearing, and so on, as I said before, 90% or more of them are in the private sector. So we need to make sure that there are some skills at lower levels of the sector, even if we get more physios and OTs, etc., into the public sector. So the last thing here is one area that has grown in the health system is the layer of managers. So Leslie perhaps can comment on this when he talks about leadership and governance. But one of the things for sure that has come about over the last several years is that most provinces have expanded the management layer. That is, deputy directors general, chief directors, directors, who are all pretty expensive, and that layer has increased much faster than the people actually doing the clinical and other work at the coal face, especially at primary level. So we had some ideas for campaigns. So one of the things we did recommend at our National Health Assembly was to develop evidence around the cost benefit of community care workers. And actually I and some others were involved in doing this. We did something called an investment case, and Treasury was convinced. We showed that the benefits from employing community care workers were greater than the costs. I won't go into the details, but one of the big benefits is giving unemployed women jobs, which then drives the economy, the rural and the urban economy. So we did this work. Treasury was convinced. They recommended that CCWs be employed. So I think that was part of the victory, but within quite a limited financial envelope because of austerity. So we actually still need to push for more. And we need to be helping community care workers who are mobilizing for more community health workers allowed to do more and for better conditions of service. We discussed with TAC, and I'm not sure they're doing this, I think they are, TAC having people based at district and sub-district level to collect data, and I think that this was mentioned yesterday by our Section 27 colleague, that they are going to be monitoring vacancies. They're going to be documenting how many posts are unfilled, starting from the clinic level and moving upwards. And then we, as PHM, could provide some training and support for this kind of work. So that's about it. I haven't covered everything on HR, but I've tried to cover the most important things that PHM believes need to be addressed if we are going to have a functioning NHI. So a people's NHI, we say, will not happen unless we deal with the human resources problem. So I'll stop there.
With regards to the human resources, we can see, as you said now, the issue with human resources, especially the clinical side with regards to the nurses.
Talk as loud as you can until the microphone arrives.
With regards to the nursing and the physiotherapists, doctors and whatsoever, many of them are within the private sector. So how would the NHI motivate them? Because the issue right now is that a lot of them don't wish to be within the public sector. How would the NHI work towards motivating them to go into the public sector?
Okay, so Leslie raised some of this yesterday. So there's discussion going on about, and in fact it's already happening, with general practitioners, that the public sector is contracting with general practitioners in areas where there aren't sufficient doctors to do sessions, for example, in the public sector. So PHM, I mean, obviously we would prefer it if it were like the British NHS, where all practitioners are in the public sector, although some of them do private work as well. We would prefer that, but we recognize that that's very unlikely, so we have to find a way of drawing on this expertise. So then government will have to enter into contracts funded through this NHI fund, but they have to make sure that they can regulate properly. Because there are already many examples, and maybe our colleague from Northwest will say something about this, of doctors who work in the public sector and are allowed to do what's called RWOPs, which stands for remunerated work outside the public sector. And actually, in some of the particularly rural provinces, often doctors are spending nearly all their time doing that and doing very little time in the public sector, but drawing their salaries. Okay, so how could regulation be done? And I hope Leslie will talk about this when he talks about governance. But there are many examples within PHM globally of what's called community monitoring of health services. So we have community structures, many of them don't work though, like health committees and so on, and we would like to see that those health committees and community structures have got the capacity to actually monitor what's going on in their health facilities. So I've seen projects in India where the kind of health committee sits outside the clinic and they note what time the doctor arrives and what time the doctor leaves, right? So kind of a watchdog. And then they hold community meetings outside the health center and they call the doctors to account, basically. So we do think that that sort of thing should be happening. Not necessarily a confrontational thing, but there needs to be much more regulation of the sector. And we don't think that the departments of health, who are sitting in the big towns, can do that sort of regulation properly. So there have to be contracts developed. And of course, as Leslie mentioned, yes, the private sector is very keen to get in on the NHI, right? Because they're having financial problems of sustainability. But we say from PHM, that's fine, but it has to be on government's terms. So it cannot be at the prices that the private sector wants. I think Monto.
Okay, I just want to add, you also mentioned physios, OTs, etc. The government hasn't actually given many posts for physios and OTs in the public sector. And I know a lot of physios and OTs and speech and hearing therapists that would actually like to work in the public sector, but there are no posts for them. So they have to go private or leave the country. So, yeah.
Yeah, and the same applies to many other categories of staff who would prefer to work in the public sector, but there are no posts.
So my question is with regards to training, and then the second one is with regards to rural. So for training for community workers, who has been training them now? I'm not quite sure who takes on that task. And now that we're going to almost formalize, I guess, the work that they're doing, who's going to regulate the community workers? Like, I'm not quite sure, who they fall under. And then my second question about rural would be, I'm curious to find out what is your on rural incentives, like the rural allowance for people who go work in rural areas, or trying to get people to rural areas. Do you think we should still be giving people rural incentives, or should we just post them there because that's your duty to work in that area? Or what they're doing now at Stellenbosch that I've noticed is getting students who are from rural areas and then sending them to medicine. But from the conversations I've had with students who come from certain areas, they don't want to go back there. They want to, continue building their own life and their family, which is fair, I guess. They've been given the opportunity. So how can we, ensure service in the rural area when we live in a urban society?
It's a really good question. So if you look, say, at the UK NHS, it's as well staffed in Newcastle as in London, right? Because the infrastructure, I'm talking schools, amenities, transport, blah, blah, is not so, there are, of course, inequalities, but there are good schools to send your kids to, right? So this question is actually tied up with a much bigger question. It's about South Africa's, let's call it, overall development policy, especially rural development policy. If the rural sector remains so underdeveloped, poor roads, poor schools, poor amenities, blah, blah, then we're always going to have this problem. So I think that the rural incentives, like the rural allowances, are like an interim measure. But I think we, as PHM, and this applies to PHM globally, we will not solve the health problems without linking up with other movements that are struggling for broader change. I know it sounds very difficult and abstract, but actually, you cannot solve health problems within the health sector alone. We talked about the social determinants. So we absolutely insist you have to try to address all of these things. Now, I can't do everything at the same time, but we should be, and we've tried to link up more with those groups that are struggling for environmental health issues. We haven't been wonderfully successful, although our Durban group is actually a group that focuses on environmental issues. So on your first question, training. So the training at the moment is done by what are called regional training centers. And unfortunately, they are not very well staffed, and I don't think they're doing such a wonderful job. And what's being used is a training manual. So it's not a manual, it's a manual. It's like you need a wheelbarrow to actually take your training manual to work with you. And it's like so many things in South Africa. We don't seem to be able to prioritize and do the basic things. There's everything in this manual. I've seen the manual. I've criticized the drafts of the manual, but it remains far too big and far too much in it, which is not absolutely key. So I think we need, and I hope Mel will talk about this later, we need much more practical training mechanisms, tools, and so on and so forth. So then that poses another question, which I didn't really touch on, which is, okay, so what about the capacity and the orientation of the training institutions? Everything from the medical schools, the nursing schools, the schools for allied health, and so on, investment in that since democracy 25 years ago has been tiny, absolutely tiny. And actually, as you possibly know, in higher education, South Africa's expenditure as a percentage of GDP is much lower than most African countries, as a percentage. I'm not saying in total amount, as a percentage. So, you know, when we have the fees must fall movement, and we basically support that as PHM, maybe not everything and not some of the tactics, but students are right. There's been too little invested in higher education. And within that, higher health education. And the orientation is poor. So it's true that Stellenbosch and some other schools are now moving towards developing rural sites. But as I understand it, Stellenbosch, that's voluntary. Not everyone goes into that stream. We're saying that should be compulsory for everyone, and that there should be much more training of health science students at low levels of the health sector, at district hospitals, at primary care level, and so on. And yeah, I'm not sure if I've answered everything. Louis, I think you wanted to. Sure.
I think you've covered me there in the last little bit about the medical school.
No, thank you very much. I think you answered a few of the things that I wanted to talk about, like decentralization of education. You know, like if maybe from experience, many GPs, because of financial problems, they want to come to the government, but they cannot. I'll give you an example of this person sitting here. I've been working in the clinics under the contract of, what do you call it, FPD. When the contract ended on NHI, I applied for almost a year into government. Even now, I'm on contract. So end of the year, I don't know where I'll be. So it's not that we don't want to come. It's just that there are no posts. You'll be told there are no posts. So that issue that GPs don't want to come is a hearsay. People don't know that, because one, the medical aids are frustrating the GPs, if you can understand that. So if you don't know that they are frustrated, so it's better to go out of the medical aid, because they are now the bosses unto themselves. They are the law unto themselves. So on the other question of NHI, how doctors will be compensated or the GPs will be contracted, we have been asking about that question. If you are using capitation, how are you going to do it? Is it going to be per area or per visit and all those things? So it is a very, very difficult issue. How is it going to be? Because even the government does not know for now. They don't know which route to follow. The RWAPS issue. I'm working with, we are 4 in a sub-district. I'm the only one who's working from 8 to 4.
You're the only one working?
From 8 to 4. My colleagues, I know, they'll say kilometers. They're traveling long distances, so we are giving 2.5 kilometers. So some days they don't go. But in actual fact, they have their private practices. So this RWAPS is happening. So I'm telling you. And then going to the rural, whether you give rural allowance or not, sometimes it depends on an individual. Like some of us, whether it was there or not, under RUDASA, if you tell yourself that you are a member of RUDASA, you'll work for the rural. You'll go, whether there is a cent there or not. So some other people, as the country is so capitalist, that to do something you have to get paid. Thank you very much.
So I didn't answer, to one of your questions about selection of students. So I think that selection from rural areas, Prof. Steve Reed here has done some work on that, and it does make a difference to whether they go back. Not all of them go back, it's true, but a much higher percentage go back than the other students who will try to avoid going to work in the rural areas. So I can understand why people avoid that, because, apart from the infrastructure, which I talked about, if, and Louis would have something to say about this, if we decentralized training so that very little of it takes place in the academic hospital and most of it takes place in lower level facilities, then we would also decentralize the support staff, the teaching staff. So then when you deploy a new doctor to a rural place, actually there's someone there who can support him or her. And when I've interviewed junior doctors working in remote parts of the Eastern Cape, they're scared. They say, we weren't trained to do this stuff. We were trained in a big hospital and we had an SHO and a registrar and a blah, 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 and all the tests. Here we have to work on our own. So this thing has to be thought through properly. So the bottom line is, we have to campaign for much more investment in human resources, including in training. So Leslie talked yesterday about Brazil. And he said, the minister went to Brazil, he was inspired, but he wants to do Brazil on the cheap. You can't do it on the cheap. I've been to Brazil, I know the guy that headed HR there. You know what they did? They built 16 state schools of public health in 16 different places. And they have these huge state schools of public health where all of the staff have to go through to get continuing education, and they're producing large numbers of middle-level workers and so on. Well, we don't have that. We got tiny little departments of public health, and most of our money comes from outside the country. We get grants from this or that funder. So we say, the Department of Health's got to get serious about this. We support NHI, as we've said yesterday, along the lines we've said, single payer, solidarity, blah, blah, blah. But there has to be investment. If there's no investment, not going to work. Because the regulation issue is complicated. He's talking about, is it capitation, which means per head of population in your catchment area? We don't know. All we do know is that there's supposed to be sub-district units that are somehow going to manage the contracts. And we say, well, district management teams can't even manage the district. How are they going to manage this contracting business unless there's huge capacitation? So this is the kind of a thing that's avoided, when we talk about the NHI. I think maybe we should stop now. So I think you've got more than enough, because HR issues will come up, I'm certain, when you run workshops in other provinces and so on. And there are some key issues, and most of those key issues on those slides, but there are other issues which will come up. So this is being recorded, so you can use some of it. Thanks.